Hi, everyone. Welcome to today's seminar, Understanding the Health and Fiscal Impacts of Medicaid Policy Proposals. I am Rachel Warner. I am the Executive Director of Penn's Leonard Davis Institute of Health Economics. So Medicaid provides affordable, comprehensive health coverage to more than 72 million low-income Americans, or more than 1 in 4 people, making it the nation's largest healthcare program. To give you an idea of its scope, it covers 40% of all children and births, 1/3 of people with disabilities, and over 60% of nursing home residents. It's also a big program in terms of dollars. It accounts for 1/5 of all U.S. healthcare spending. That includes 60% of all spending on long-term care, 70% of all spending on home and community-based services. And it's the largest funder of behavioral health services, treatment for substance use disorders, and services for people with HIV. Medicaid's large role in the federal budget has made it a target for cuts. The House passed a budget resolution in February targeting cuts to Medicaid of up to $880 billion to help pay for tax cuts. The Senate has yet to formally weigh in on the amount and the types of cuts to Medicaid they will support. But there are a number of options on the table, including imposing work requirements, which would limit enrollment, curbing the use of provider taxes, which states use to fund their share of Medicaid payments, thus increasing federal matching to the state. There are also proposals that have been floated, such as capping federal spending on a per enrollee basis, using block grants to fund Medicaid, and lowering the federal matching rate to states. Large-scale reductions to federal Medicaid spending would have far-reaching consequences for state budgets, for the broader economy, and the health and well-being of Medicaid enrollees. Today, we're joined by an outstanding group of panelists who will help us understand these changes and their financial and health impacts. So without further ado, I will introduce our panelists. Valerie Arkush is the Secretary of Human Services in Pennsylvania, the agency that administers the Medicaid program here in Pennsylvania. She's also a physician and a public health leader and served on the Montgomery County Board of Commissioners. Joe Benitez is an assistant professor in the Martin School of Public Policy and Administration at the University of Kentucky, with expertise in Medicaid policy and Medicaid program design, including Medicaid's role as a safety net program. Adriana McIntyre is an assistant professor of health policy and politics at the Harvard T.H. Chan School of Public Health, where she studies the politics of health reform and strategies to improve take-up and retention of subsidized health insurance and other social programs. And Mark Zandi is chief economist of Moody's Analytics, where he directs economic research. He frequently testifies before Congress and conducts regular briefings on the economy for private sector leaders and policymakers. So thank you all so much for joining us today. I'm looking forward to this timely conversation. Adriana, I want to start with you and ask if you can do a little level setting for us and give us a brief primer on the way in which the federal and state governments currently work together to fund and operate Medicaid.
Sure. You stole a few of the stats I was going to throw out there in terms of the number of kids covered by Medicaid. So as Rachel said, Medicaid is really an essential part of the fabric of U.S. healthcare. It covers about 1 in 5 Americans, 1 in 4 Americans, 40% of kids, 40% of births, over half of nursing home care in this country. It's financed as a state-federal partnership. So whereas Medicare, the program for older Americans, is entirely a federal program, Medicaid is a partnership between the federal government and the states. The federal government offers funding to states who are responsible for co-funding and implementing the program. And the way that the program is funded is a little bit complicated. So for enrollees who have historically been part of the program, since before the ACA created Medicaid expansion, there's something called the federal match rate, the FMAP. And that ranges from 50% to about 75, 78%. In the federal match rate is calculated based in part on states' median income, household income. So how wealthy are residents of the state? Wealthier states have lower match rates. So Massachusetts is one of the states that has a 50% match rate. For every dollar the state puts in, the federal government puts in another dollar. Mississippi is the lowest income of the states in the US. They have a match rate that's a little bit over 75%, meaning that for every dollar Mississippi spends, the federal government pitches in $3. For expansion, the expansion population, the people who gained coverage after the Affordable Care Act gave states the option to expand coverage to everybody below a specific income threshold, the federal government picks up 90% of the rate of the payments there. One thing I will note is that when we talk about Medicaid enrollment, it's not one-to-one in terms of enrollment and spending. So people who qualify for Medicaid on the basis of being older or having a disability and being low income, they make up about a quarter of the program, but they also make up about 50% of spending. So that they have an outsized impact on spending, which matters when we start thinking through implications for reform. Medicaid as a program is pretty comprehensive health insurance. It covers, most medical services you would expect a health insurance program to cover, and it tends to cover it with with no or very low copays or cost sharing at point of service. There are exceptions to this, and cost sharing is more common in benefits that are optional, like dental or vision, which not all states cover. But in general, it's quite extensive insurance, which also means that the options available to states to sort of rein in spending are fairly limited. Or if the Congress moves forward with some of the proposed cuts, the options that are available to them are somewhat limited. They could put up their own state dollars. As I'm sure Mark will talk about, that might be increasingly difficult as a proposition given the current economic climate. They could find ways to reduce the number of people who are covered, either changing eligibility criteria within their ability under the law, or doing things, introducing administrative burdens that make it harder for people to stay enrolled over time. And I'm sure we'll come back to talking about work requirements and how those affect enrollment. They can change the specific benefits that are covered. A number of benefits fall under this optional category where states could, play around with how they restrict access to optional benefits. And then, of course, they could reduce payments to providers. That's one of the tools available to them. So that's sort of the big picture. Was there anything else you wanted me to touch on?
That was an outstanding big picture. Thank you so much. Let me move on and we'll come back. You've raised a lot of really important issues that we need to unpack, but I will come back to you on those. I want to, Val, move on to you for a minute. So you're the leader of the agency in Pennsylvania that actually runs Medicaid and facing decisions potentially about how Medicaid will have to change under these federal cuts. So can you tell us a little bit about how Pennsylvania is thinking about potentially changing what options you have to respond to Medicaid cuts?
Well, let me start with taking that excellent summary of the Medicaid program. I'm not sure I've seen anyone do it so comprehensively and so quickly, and bring it home here to Pennsylvania, because I'm guessing a lot of the folks watching are from the Commonwealth. So currently, our Medicaid program covers 3 million Pennsylvanians. 3 million people get their health care through Medicaid. That is nearly one quarter of Pennsylvania's population. Of that group, 1.3 million are children, 425,000 are individuals with disabilities, 312,000 are older adults, 65 or older, and almost 10,000 are veterans. And I want to focus in on the expansion population for just a second. As was noted, under the Affordable Care Act, states had the option to expand Medicaid. Pennsylvania did that a little bit later than some of the other states. We did that in 2015. Since we have done that, the uninsured rate in Pennsylvania was cut in half. It went from about 10% to just under 5%. And there are 750,000 Pennsylvanians that are covered in that expansion population. And another really important factor that I think sometimes doesn't get enough attention in this discussion is that since Pennsylvania expanded Medicaid, we have reduced the uncompensated care rate for our hospitals by 27.7%. So I think it's very important as we think about the impacts of these proposed cuts. Not only is it deeply impactful for people, for families, for older adults, for individuals with disabilities and children, for pregnant people, but the whole healthcare ecosystem will be dramatically impacted by this. I think some of us on this call remember practicing before the ACA. And I always worked at Philadelphia teaching hospitals, and on any given day, 20% of my patients might not have health insurance. And so our hospitals, which across the state and across the country are running on very, very slim margins, they have nothing to spare here in terms of having to accommodate higher rates of uncompensated care. So as we look at some of these proposed cuts, they are catastrophic and would be catastrophic for every state, including the Commonwealth. The options are relatively straightforward. I think that folks can assume that fewer people would have health care. There would be more uninsured individuals. Those individuals that do have health care would have fewer benefits. And our hospitals, doctors, nurse practitioners, other providers would see a much larger number of individuals without health insurance at all and would have to figure out how to or could they provide that uncompensated care.
Let me ask you a follow-up question, which is that you've talked about ways in which Medicaid would have to shrink facing these cuts. I think there have been some people who have suggested that one way that states could respond is by increasing spending on Medicaid, either increasing taxes or diverting money from other parts of the state budget back to Medicaid. Can you tell me a little bit about how Pennsylvania's thinking about those two options?
Yeah. So it's a very tight budget year here for us in the Commonwealth. And just to expand on that FMAP conversation that you heard a minute ago. So here in Pennsylvania, our regular Medicaid population, we have a federal match of a little over 56%. And so, for every dollar, the federal government pays about 56 cents and the state pays about 44 cents. And then for that expansion population, federal government pays 90 cents and we pay 10. So let's just focus in on that expansion population. As I mentioned, we have 750,000 people in that group. If, as one of the proposals, for instance, is that a state would not get that 90% match any longer, it would drop it down to that 56% match. The Commonwealth would have to go from paying 10 cents on every dollar to paying 44 cents on every dollar for 750,000 people. It is very unlikely that those kinds of dollars could be found in our current state budget.
Yep. Okay. Thanks for clarifying that. Mark, I want to move to you next. I want to zoom out a little bit to the national landscape and ask you about the capacity of states related to what Val was talking about to manage federal cuts of the magnitude that are being discussed. And if you could also touch on what the effects of Medicaid spending reductions might be on in terms of economics and financial outlook in states, that would be great too.
Yeah, sure. And thanks for the opportunity to participate. And I am a Pennsylvania resident, so go Birds from Philadelphia. And I think what we heard from the secretary is common around the country, very tight budgets. And that's after a period of pretty good economic growth. If you go back, over the last couple, 3 years, on the other side of the pandemic, 22, 23, 24, those were pretty good years for state governments. The economy was cooperating. We had our problems, obviously, with inflation, but everyone had a job, 4% unemployment rate. That rarely happens. That happened one other time in the post-World War II period. Low across the country, from Pennsylvania all the way to California. Lots of jobs, lots of income, businesses doing very well, highly profitable, real estate values appreciating and housing values, and all those things are key to revenue growth, right? So they drive revenues. So revenue growth was good right up through last year. I think as if I recall correctly, if I look across the country, add up all the state revenue, grew about 5% in 2024 over 2023. That's good. That's quite good. Of course, in that period, there was a lot of help from the federal government as well, right? The spending that came out of the COVID relief legislation in early 2021 has been very helpful to a lot of state budgets. A lot of money for infrastructure spending. There was a federal bill that was passed that helped support a lot of infrastructure spending. So states, came into this year, I think, in a good spot, pretty good spot. But that's the end of the good news. Things are turning here pretty quickly. The economy is struggling. We can see it in the stock market over the last couple of days. It goes to the trade war we're now in the middle of. Obviously a lot of different scenarios here how this can play out, but increasingly they're all getting darker, pretty fast. And I think the damage has already been done. Even if the trade war can be turned around here quickly, the economy is diminished by this. So states are just not going to be able, even under reasonably optimistic scenarios, generate the kind of revenues that they have been, over the last several years. It's going to be a much more difficult environment for revenue going forward here, at least for the foreseeable future. On top of that, the states are under a lot of pressure on the cost side. The federal government is really critical to providing support to state governments in lots of different ways. All those funding sources are under tremendous pressure. Symptomatic of the DOGE cuts to jobs and government funding. It's just very significant already, having impacts everywhere. And lots of things that states count on are really now under question, like money for emergency relief. What's going to happen the next time a big storm blows through the state of Pennsylvania? What are we going to do? Where's that money going to come from? So all of that is the kind of the backdrop for, now considering massive cuts to Medicaid. I mean, we're talking hundreds of billions of dollars in cuts. This is the single, as was already been pointed out, the obvious, this is the single most important expenditure for most states, 30% of their budget. So you cut that funding, you got some pretty hard choices to make here. You either raise taxes, which just, I wouldn't count on that. You cut the kind of benefits you provide through Medicaid. Seems like that's partly where you'd go. Or you cut other spending that the states do. And of course, the other big expenditure is education. So we just take from the education budget to help pay for the Medicaid. So, this feels like a very vexed kind of environment coming forward. And, I'll end by saying, these cuts have consequence, not obviously for the kind of lower income households that are so dependent on them. I mean, this is healthcare we're talking about. I mean, this is not, a luxury. This is, a necessity. People need healthcare, and we're cutting that. You just can't ignore that. You cut that spending, you cut those benefits, it puts pressure on the entire healthcare system, which has reverberations throughout the economy. I mean, particularly in a state like Pennsylvania, particularly here in Philadelphia, we're eds and meds, and you cut that, and you're going to hurt the economy. It becomes self-reinforcing. You get into this kind of vicious cycle. Final thing I'll say is, hopefully we don't go into a recession. And by the way, those risks are now rising pretty considerably. I wouldn't rule that out. In times past, the federal government would step in and help states, right? Because states have these fiscal binders on. Most states. They can't deficit finance for any length of time. So if they don't get support in that environment and they start cutting spending, it just exacerbates the economic downturn. It's exactly the opposite of what you want to do. But in this current environment, I don't think the state should count on the federal government coming to anybody's rescue. It's just not going to happen. So I think this is a big deal, really a big problem. I think the federal policymakers are looking in the wrong place to try to address these issues.
Thanks for that. So just following up on the question about the recession, there are increasing by the hour, by the day, fears of recession. And you talked about the federal dollars being important in the recession. The other thing that happens is increased enrollment in Medicaid, increased demand for Medicaid. And so can you just talk a little bit more about the fears around recession related to that?
Yeah, I mean, recessions are pretty hard on the finances of government, state, local, federal. The obvious is it hurts revenue. There's no doubt about that. Profits are down, therefore corporate profit taxes are down. But people's incomes are down, therefore personal income tax is down. People spend less, therefore sales taxes are down. Housing values, CRE prices, commercial real estate values come under pressure. That lowers property tax revenue with a lag. And then it raises expenditures. It's built in. It's built in, because people get hit financially, and they then more people qualify for the programs that are available to them, Medicaid being one of them. But that's only just one of them. There's many, 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 support programs that, the cost will rise because people will need those, food assistance, rental assistance, transportation assistance, all kinds of things. So the finances of state governments are, very what economists call pro-cyclical. When things are bad, they are really bad. And that's why historically the federal government always comes in to help out. And again, in the current context, hard to imagine that happening. So I think the states are on their own this time, and that just exacerbates the broader economic problems that we're going to struggle with here.
And Rachel, can I just jump in on
Yeah.
that one just very quickly? I just want to remind everybody, we just did that thought experiment in real time with the COVID-19 pandemic. And the presence of Medicaid as people were being laid off from their jobs in the early days of the pandemic in March of 2020, the presence of Medicaid was absolutely essential to making sure that individuals were able to access healthcare. And I can tell you here in the Commonwealth, because we finished the what we called colloquially the unwinding, that redetermination of eligibility for all the folks that had come into Medicaid during the pandemic and were not disenrolled until the public health emergency was over. Here in the Commonwealth, it was netted out to be around 650, 700,000 people that got health insurance during the pandemic just because Medicaid was here for them. We were here when they needed us, and so was SNAP, our primary food assistance program. So these programs are essential, and they're particularly important when there's a downturn in the economy for any reason.
Yeah. Okay, thanks. Um, Joe, I want to pivot a little and bring you into the conversation. Um, One of the things that sometimes comes up when people talk about Medicaid cuts is whether or not Medicaid actually provides good value. Does it provide high quality coverage to the people who are enrolled? And so I wondered if you could touch a little bit on what we know about the program's strengths in terms of quality and its impacts on the beneficiaries it covers.
Sure. First of all, thank you so much for inviting me to be on this panel. Uh, feel very fortunate to be here and to be a part of this conversation. I would also like to add to some of the sentiments brought up by both Val and Mark, and how during the most recent economic downturn that was during the COVID-19 pandemic, about how people used Medicaid. So especially for people that lost their jobs during the early part of the pandemic, it's not just a part of helping them maintain coverage, but it provided some protections from medical debt and delaying healthcare that they might have otherwise not sought out if they were otherwise uncovered by Medicaid or potentially employer or private health insurance coverage that they might have lost. Now going back to the specific question, relative to being uninsured, Medicaid is generally associated with improving access to healthcare, providing people with the resources that they need to get the care that they need. Even some evidence of improving in health outcomes, as well as some protections from even avoidable mortality in some groups. Now, even beyond just the direct health effects of Medicaid coverage, or which we could say just having health insurance coverage of any kind at all, Medicaid is increasingly known for financial protection, so protecting people from medical debt, even protection from rental evictions and material hardships, such as the financial burden of being in poverty. Even considering the broader stability of the healthcare ecosystem, as Val was mentioning earlier, allowing with the case of Medicaid expansion, it allowed some hospitals to fare financially better when compared against hospitals in states that had not expanded Medicaid or expanded Medicaid to a larger share of the income population. So we see that these are vital effects for the stability of the healthcare system, especially when you think about hospitals that normally serve vulnerable populations who are disproportionately on Medicaid or would be historically low income or in some cases uninsured. So hospitals or healthcare facilities that often act as safety net providers. So there's some stability coming to these facilities because of improving coverage stability and the maintenance of coverage. There's a lot of ongoing questions in both in research and policy circles around what does healthcare access and what does quality look like within the Medicaid program. A lot of that is focusing on the quality of the provider network. So the extent that providers are both being reimbursed well and even participating in Medicaid programs, because just having Medicaid coverage doesn't mean much for beneficiaries if there's relatively few providers that accept Medicaid. So you can run into some potential issues there. One of the things that we know that generally helps to create some stability in provider networks is increased payment rates, which comes back into how states reimburse providers, as well as how much they invest in this source of spending. We know that increasing reimbursement rates tends to lead to both improvements in healthcare access, but also leads to improvements in provider participation, both for primary care, but also in certain areas of specialty care. I would imagine that some of the things that were of concern with potential Medicaid cuts is if provider participation starts to drop as Medicaid spending at the federal level is rolled back, and what states might have to consider doing. On the enrollee side, we know that some states could consider how they either restrict or change their eligibility guidelines, such as either they roll back their expansions if they've expanded Medicaid, if they reapply categorical restrictions, such as limiting Medicaid coverage to parents, or even limiting, say, the optional benefits that were discussed by Adriana at the beginning of the panel, such as whether states decide to roll back dental care, prescription drug coverage, or changing the drug formularies, rolling back vision care, or even hospice care. So these are some of the major considerations that at least I think about in terms of Medicaid spending, but also in terms of how states provide quality programs.
Okay, thanks. I want to get to some of the specific ways that have been floated that Congress is thinking about cutting Medicaid spending at the federal level. Nobody really knows what's going to happen, and the list sometimes changes. But one of the things that's been at the top of the list has been changing rules around provider taxes. And so, Adriana, maybe I'll start with you, but would love to hear from all of you. Can you explain a little bit about the ways in which the federal government is thinking about cutting back on Medicaid spending, and maybe specifically touching on provider taxes?
Yeah, sure. So backing up, we don't know a lot about, as Rachel said, we don't know a lot about what specifically Republicans are contemplating, although the budget instructions that have passed the House have suggested that a committee within the House called the Energy and Commerce Committee is supposed to find $880 billion in savings over 10 years. And that matters because reconciliation is this strange legislative process that has a bunch of arcane rules. If Medicare is off the table, Medicaid is basically the only place that this committee can go for savings. They have jurisdiction over various policy domains, Medicare and Medicaid being the biggest among them. And President Trump and congressional Republicans have repeatedly said that they won't touch Medicare. So that just leaves Medicaid. $880 billion over 10 years is a lot of money in Medicaid. So a number of things have been floated to try to get to this number. One of them is, and this has been alluded to a little bit, dropping the match rate for the expansion population from 90% down to whatever the states is. So 54% in Pennsylvania, 50% in Massachusetts, 75% in Mississippi. One thing that's notable about that proposal is that I think it's 9 states have what we call a trigger law on the books, meaning if match falls below 90% for the expansion population, their expansion just goes away. It's how the expansion was passed in the first place. Another proposal that has been floated is shifting to per capita caps, which is the idea of the federal government paying a specific sum of money for each enrollee. Again, we haven't seen detailed proposals, so we don't know exactly what that would look like. Some proposals in the past have said, well, there's going to be one per capita amount for older Americans, a different per capita amount for disabled Americans, a different one for expansion adults, for kids. There have been some proposals to limit per capita the per capita approach to just the expansion population. I think that operationalizing that is more complicated than it sounds. And then there have also been these discussions around provider taxes and MCO taxes, taxes on managed care organizations, the insurers who administer the Medicaid program. These are fairly complicated policies, and I don't know that it's worth getting into the details here, but in 2018, there was an estimate that almost 20% of state Medicaid dollars came from these provider taxes. It's basically a way for states to generate state federal match dollars, and it gives them some flexibility in how they can spend their Medicaid dollars beyond just here's a dollar for this specific service that you delivered. That has been, the provider taxes have come under scrutiny in the past. And I think that one of the reasons they're on the table now is because there are potentially quite a lot of dollars at stake here. But it's important to remember that if you turn that off overnight and you say save $600 billion, that's $600 billion that the states no longer have that they did yesterday. And it's just like a cut. States will need to figure out how to make that up. And they will face those same decisions about whether it's substituting state dollars, which we heard was going to be very difficult, covering fewer people, covering fewer benefits, or paying providers less. So I'll pause there and see if my co-panelists have anything they want to add.
I'll just add that 49 states make use of these assessments, and well more than half, I think it's around close to 40 states, use 3 or more of these assessments. And so again, this would be just another cost shift to the states. Yes, in theory, it would save money for the federal government, but it puts an enormous burden on the states that would be quite difficult, I think, for just about any state to make up for.
One thing I think about with per capita caps and Medicaid coverage is it would limit how well states could respond to emergencies like economic downturns or anything where there's a sudden increased demand for Medicaid coverage. And this could not only include these national downturns, it could be a state or localized recession or the exits of large employers where many people might otherwise get private health insurance coverage, but now people have to turn to Medicaid or alternative sources of coverage in the meantime.
And a key question with per capita caps that, again, we don't have clarity on right now is how you would index the growth of those payments over time. And so if you index it more slowly than costs actually rise, you in theory save more federal dollars, but that doesn't change the fact that services are going to cost more as time passes. And again, it becomes this question of, do states pony up additional dollars? Do they find a way to do that? Or do they have to make cuts in these other dimensions that end up hurting patients and hurting providers?
One other proposal that we haven't gone into in depth really, but has mentioned in passing is work requirements. And Joe, maybe we actually know a bit about work requirements and how they work and the evidence around their effectiveness. Can you talk a little bit about work requirements?
Sure. So work requirements, broadly speaking, would require Medicaid beneficiaries or either how states outline their programs, whether it applies to all eligible adults or adults within the expansion population. What we've seen is states generally focus on the expansion population. So these slightly higher, but still low income adults. One of the things I've always been concerned with is the extent that work requirements create a barrier for people that might otherwise use Medicaid as a safety net program. And in the same way that they would use unemployment insurance. So people become unemployed, or detached from commercial health insurance coverage, the extent that they can use Medicaid as a way to stay afloat or maintain access to healthcare and provide some coverage stability. There's been very few states that have fully implemented work requirements, and even those that have are going through some changes. Probably most notable will be Arkansas, and then more recently Georgia, who's even including or recently submitted an amendment to their initial Section 1115 demonstration project on work requirements. Let's see, Ohio has recently uh, you know, look to implement work requirements in their Medicaid programs as of late March. Kentucky, where I live, has the Kentucky legislature has voted to approve Medicaid work requirements and incorporating into law. Their work requirements would apply to adults or able-bodied adults without disabilities that are aged 18 to 60, and it would require them to work at least 20 hours a week or verify that they are working 20 hours a week. The specific language in the bill is that they are people that must be physically and mentally able to work as determined by the Cabinet for Health and Family Services, but it's also going to have some provisions where I guess validation of community engagement activities with the Department of Education or the Kentucky Department of Education and the labor cabinet. So that could potentially provide some synergies on the back end. But pending CMS approval or Centers for Medicare and Medicaid approval, the mandatory community engagement would include any job placement activities, working, and then CHF, the Cabinet for Health and Family Services, could work with other cabinet level or agencies within Kentucky to determine how to proceed. Georgia and their Pathways to Coverage program, it was a moderate expansion. So essentially expanding Medicaid coverage to 100% FPL, but then some of their stipulations, at least seen early on, might have led to lower than expected participation in the program. So I think that led to the January 2025 amendment to their activities. So some of the things that they are looking to do with the amendment is discontinue monthly reporting, which we know that the reporting imposes some administrative burden on just participating in the program. They would add additional qualifying activities, such as schooling or how schooling is captured. They would remove premium payments, which we very rarely see premiums used in Medicaid programs, and then also installing coverage retroactively to the first of the month when they applied for coverage. There's not really a whole lot of evidence in the literature to suggest that Medicaid work requirements actually increase work participation, or labor market participation. But we do know that they tend to be associated with loss of coverage, disruptions in people getting needed care or avoiding or delaying needed care because of cost, and even from Arkansas, increases in medical debt that people might not have otherwise experienced had they been able to maintain their coverage.
Yeah.
Can I just a quick comment? Of all the proposals to cut Medicaid, this is one I just don't get. If you actually look at Medicaid recipients that are under the age of 65 who don't receive disability benefits, I think the labor force participation rate is exactly equal to the rest of the labor force, the 64, 65, 66%. So exactly what problem are we fixing here? I just don't get it. And then if you actually look at I think Adriana mentioned they want 880 billion, I think, over 10 years. If you look at their proposal on work, this is the House legislation, looking at that, look at the work requirement piece of that, that's 100 and 50 billion maybe. I'm making that up, but something in that ballpark. And then if you consider all the administrative costs that are involved, the net, I'm not sure. This is the one I get it. I get it. It's intuitive. I can see the politics of it, but it seems very performative to me and not at all substantive and just a big waste of time. So that's the one I just don't get at all.
I mean, I think that's right. It's largely a solution in search of a problem. If you look at, estimates, something like 92% of Medicaid enrollees who are non-elderly adults meet the exemption criteria. The problem is that being exempt in practice and being exempt from the program, from the work requirements themselves are very different because the systems can't automatically know, or it's hard for systems to automatically know if you meet a lot of the exemptions. Do you have a disability even though you didn't enter Medicaid through the disability pathway? Lots of people on Medicaid have disabilities, even if they're sort of expansion enrollees. Are you in school? States might have systems that can tell you about people's employment status, but that varies a lot by state. The quality and timeliness of that data varies a lot by state. So there tend to be these reporting requirements, and it's the reporting part of the work reporting requirement, not the work part, that tends to screen people out of coverage.
Yeah,
Right.
I just have to add one more thing that this is, at the end of the day, for all the reasons that you just heard, a true unfunded mandate to the states. I do believe that the federal government would save some money for all the reasons you heard. These programs create enormous barriers to participation in Medicaid. But depending on how the programs were constructed and sort of what the rules were, those details are obviously extremely important. The administrative burden to the states to monitor and document all of these criteria is enormous. And what hasn't been mentioned is it also means that we would need to ramp up our job training programs. We would need to ramp up our subsidized childcare programs for low-income working parents. There are costs from doing this that are beyond the Medicaid program itself. And so from the state perspective, this is a money loser all the way around with no federal dollars to help support the implementation of work requirements.
Okay. That was great. Thank you. I want to ask now about fraud, waste, and abuse. And so fraud, waste, and abuse is often touted as being a source of large-scale savings if we can rein in fraud, waste, and abuse. And I'd love to hear from each of you what your perspective is on the scale of savings that might be found through this mechanism. How much fraud, waste, and abuse is there?
I'm happy to start with that one. So first, I want to say that we take fraud, waste, and abuse extremely seriously in Pennsylvania. I feel as a public servant, I was a former elected official, it is just essential that taxpayer dollars go where they were intended to go. And that these programs are vital programs, as we've been talking about, and every dollar that is allocated to them needs to go to the program. So this is something that we take very seriously here. As evidence of that seriousness, the U.S. Department of Health and Human Services put out a report about a week and a half ago, naming Pennsylvania as #1 in the country in fraud charges and #3 in convictions and in the Medicaid program. And that happens because my team works every day to identify any sort of fraud in the program. When we see evidence of fraud, and we have multiple programs that we use, databases that are checked against regularly, Social Security, death records, disability records, all these programs are checked regularly. And we have recently instituted something called fraud capture, which uses AI algorithms to look at patterns of spend and then kick something up to a person if the AI detects an unusual or suspicious pattern. So just the whole constellation of that, when we see something suspicious, then we send it to either our Attorney General's office or our State Inspector General's office, depending on what the concern is, and then they are able to actually do a true investigation and bring charges if possible. The other piece that we do is something called third-party liability. And as I'm sure many of you know, Medicaid is always the payer of last resort. And it is often the situation that an individual has some other type of insurance, even if it's a very small plan through an employer, maybe it's Medicare, maybe it's a veterans benefit. There's sometimes other insurances that can be brought to bear. And so I have a whole team. All they do is make sure that there is no one else who can cover a particular charge for a particular individual. And that team in our state fiscal year 23-24 realized more than $490 million in recoveries and cost avoidance just in 1 year. And then finally, our program here in the Commonwealth is administered through contracts with managed care organizations, all of whom are 100% capitated, so they're fully at risk. And as part of the development of their rates every year, we look at what we call efficiencies. And so we look at avoidable hospitalizations, unnecessary cesarean deliveries, things like that. And we will actually reduce pull back some of their dollars based on those efficiencies. That becomes the new baseline for rate development for the next year. And to give you a sense of that, in the last 5 years, we've pulled $1 billion out of rates for our managed care organizations here in Pennsylvania. So I share all of that because I can't speak for the other states, but I can speak for Pennsylvania. We run an extremely lean operation here. We are cracking down on any type of fraud or abuse of the system. And there's really minimal, I'm not saying we're perfect, but I think there's really minimal savings to be found in that type of work.
I have a few points I'd like to add. One thing I like to tell my students is, as much as we might like it, I think that, there could be some consensus around targeting waste, fraud, and abuse for savings, but there aren't bags of cash labeled waste, fraud, and abuse that we can go pick up and put in the US Treasury, right? Like the incidences of waste, fraud, and abuse are sort of marbled throughout the system, and they're really hard to surgically excise. And while we might be able to come to a consensus definition of fraud, I think that waste and abuse are in the eye of the beholder a lot of times. And so that really complicates our policy conversations. There are people who will say provider taxes, MCO taxes are a form of waste or abuse, but to states, those are just the Medicaid dollars that they've relied on for years. And so to change the financing mechanisms overnight would be a real shock. And then the last point I want to make is a lot of the proposals that are currently under consideration aren't proposals that you would imagine do a lot to address waste, fraud, and abuse. Bluntly cutting FMAP, moving to per capita caps, the work requirements. So some people might perceive people not working on Medicaid as a form of abuse, but the best evidence suggests that what work requirements do is screen out people who are in compliance, just failing to do the reporting. So I think that it's hard in part rhetorically because waste and abuse are different to each and every person. But there's also a mismatch between saying we want to target waste, fraud, and abuse and the solutions that are being proposed.
Thanks. So if there's nothing else on fraud, waste, and abuse, the hour is going by quickly and there's so much we could talk about. One of the things I wanted to ask you is that we may be at a place where Medicaid is going to be cut. And if some amount of savings have to be found in Medicaid, what are your recommendations about how Congress should make that reduction? What's the least harmful way to cut Medicaid, in your view, if there is one?
Well, I don't know the answer to that question. I'll let the experts weigh in, but I'll just push back on what you just said. I'm not so sure. I mean, it doesn't feel like the Senate's got any appetite for this, and the president says lots of things, but he just said I'm not cutting Medicaid. So and if you actually talk to congressmen in rural areas of the country, which tend to be Republican, they're hair on fire, over this because, every hospital in those communities drives the economic engine of those communities. That they're the largest employer. They're key to success. If you don't have if you don't have a hospital in your community, your economy is not going anywhere. Your community is going nowhere. And they know that those hospitals depend critically on these Medicaid dollars. So I think the odds of this happening are low.
When you say, let me just clarify, when you say this, do you mean 880 billion or do you mean,
$880 billion in
okay.
cuts, or there might be some cuts, maybe work requirements because it's just, the politics of it. But I'm increasingly of the mind that that's not what's going to happen here. That'd be unlikely. Not that we shouldn't have forums like this to discuss, and not that we shouldn't think about it. I'm not arguing any of that. I'm just saying it just doesn't feel like this is going to go, to the finish line, get to the finish line.
Anyone else want to weigh in?
I guess one thing that's just like Mark was mentioning, communities and even increasingly people is really hard to find, say, constituents who either themselves or someone in their immediate lives who have not been touched by the Medicaid program, at least in some meaningful way, or even a past experience with the Medicaid program. One of the things that that could be thought about is not just about who's on Medicaid today, but who could be on Medicaid tomorrow, and what types of barriers might be put in place for keeping people who would otherwise benefit from the program and keeping them out of the program, whether it's someone who, say it is a person that experiences a job loss. These would not be people who would be on Medicaid for a long time. It would likely be until they possibly transition back to a job that does offer employer employer-based coverage or allows them to afford, say, marketplace coverage, for example. So, to the broader stability of economies as a whole, if there aren't resources to fund your key employer, which in many rural communities that would be a hospital, that does create some problems in the economic viability of that entire community if the hospital were to close or not be financially viable.
I'm also sort of hard pressed to come up with ideas to sort of meet the thresholds that Congress is talking about. Medicaid already pays less than Medicare does. There are access issues associated with the rates that Medicaid pays, that creates equity issues. It just feels like such a lean program to be going to. It's already so lean, so to be going there for savings feels really, really challenging. I can comment on what I think is most likely to happen, or what policies are sort of at the top of the list. And they're policies that don't get a lot of attention because they're hard to organize and message around. There were some regulations the Biden administration finalized in 2024 that were going to make it easier to get and stay enrolled in Medicaid, including for aged and disabled enrollees. And when you increase coverage, you increase spending. And so if you take back that rule and you don't have those increases in enrollment, you have decreased spending. And so there are a few different rules, including, Rachel, I believe you've written about the nursing home staff ratios rule. There are a number of regulations that were intended to sort of strengthen the program for Medicaid beneficiaries that Congress could propose to roll back and achieve savings that way. And it's really hard to message around saying, no, we want to keep these regulations in place. Regulation is sort of a four-letter word in the US. And so I think that that's probably top of mind for members of Congress. Now, if the estimates are right, there's this memo floating around with estimates of how much you can save by rescinding each of these rules. It doesn't get them to 880 billion, but it might get them to 400 or 500 if you stack those regulation repeals with work requirements. And I think that that's probably the most likely outcome, but there are still going to be people who lose coverage or don't get coverage as a result.
Right. So part of the strategy there is to, in addition to like getting rid of nursing home staffing requirements, things like that, it's just making it harder for people to stay on Medicaid and therefore spend less money because of it. Yeah. Val?
Yeah, I think that Congress needs to look somewhere else, frankly. The impact on our communities, not just in the terms of the human cost, but on all of the institutions around providing these services is devastating. Medicaid runs so lean, as we've been talking about. Nationally, the administrative costs in Medicaid are like 3.9%. There's no commercial insurance company that comes close to that low of an administrative cost rate. This is a program that delivers, really punches way above its weight and helps the most vulnerable people in our community. Our rural hospitals, about half of them have a margin of zero or a slightly negative margin, in some cases, a fairly big negative margin. If they need to start providing more uncompensated care, it will be a death knell for them. And it was pointed out, when a hospital leaves a community, oftentimes that is the beginning of the end for that community. It's very hard to attract new businesses, young families to a community that doesn't have a hospital. And the impact on our workforce will also be very severe. In the discussion of work requirements, nobody ever talks about the fact that many people are able to work because they have Medicaid and they can get the health care that they need to keep them healthy. And so when you put barriers up to them keeping that health care, that might actually end up leading someone to leave the workplace, not by choice, but out of necessity because they're now less healthy. And so healthcare is just fundamental to thriving communities. Our families can't be stable without it. And I really urge our policymakers to look in other places rather than this very essential core need that we have as humans. And hopefully they can find some savings somewhere else.
Okay, thank you. I want to give each of you, and Val, I don't know if there's anything you want to add, but parting thoughts. Like, what message do you want to get to federal policymakers as they deliberate on this question in the federal budget? And so we only have about 4 minutes left. So if each of you wants to take about a minute and say what's on top of mind for you for federal policymakers.
So I just think the idea of targeting cuts to even specific populations within Medicaid is something of a fallacy. We all rely on the same doctors, the same hospitals. And so if cuts to Medicaid expansion hurt doctors and hospitals, that's going to have ripple effects for the rest of us. And I think it'll take a little bit longer for us to feel that. But as we've been talking about, Medicaid is really just part of the fabric of US healthcare. It's not just for the people on Medicaid, but for the rest of us too.
Well, I'll just say, look, I'm very sympathetic to the concern that the nation has some very deep fiscal problems. There's no doubt about that. We're running a budget deficit nationally that's about 6% of GDP. And even excluding interest payments on that debt, it's 3%, the primary deficit. And that's in a full employment economy. That's pretty serious. The debt load is rising quickly, and there will be economic repercussions for that. So we do need to address this. But, in the large list of things we can think about on the revenue side and on the spending side, and that's how you address it. And also think things about how do you improve growth, going back to things like immigration policy. I would put the, cuts to Medicaid, at that bottom of that list. I just don't think that's the place you'd want to look. So I get the difficulty here. This is really tough, if you're trying to figure this out, how to address the fiscal situation. But I would strongly argue this is, to echo other comments, not the place to look.
Yes, any changes to the Medicaid program should also consider other indirect or even potentially negative spillover effects. So you cut Medicaid, you cut access, you strict eligibility. Like, what could be some far-reaching effects that you experience in the later that lead to other forms of needs for government spending that could have been potentially averted because the Medicaid program exists in a way that allows people to not only address their healthcare needs, but even address some of their just broader economic needs, such as food security, protections from poverty, protections from other forms of material hardship. I'm glad that Val brought up the point earlier about things that they're fraudulent in Pennsylvania, another Commonwealth, I come from Commonwealth of Kentucky, about using AI to identify potential sources of fraud. So provide resources for states to either expand their Medicaid fraud investigation units, allow for them to be more advanced in terms of identifying potential inefficiencies or outliers in terms of spending, use, and even within the claims. So I think these are some things that could be incentivized across the board for states in terms of like trying to find spending that, I don't want to say waste, but spending that could otherwise be unproductive.
Great. Val, any? You're good? You're
Real quick, just want to remind folks, we're talking about people here. This is, at the end of the day, it's about older adults, people with disabilities, pregnant people, and a whole bunch of kids. And cuts to these programs will not only affect all of that group of people, but it will impact all of us, as Adriana noted. It will increase crowding in emergency rooms. When people don't have health insurance, they don't have anywhere to go but an emergency room. People might remember before the Affordable Care Act, insurance premiums were going up at a much faster rate year over year than they are now because hospitals had no choice but cost shift to folks who were fortunate enough to have health insurance. So all of those impacts, this is not a population that lives in a silo. These are the people that live next door to us, that help us at the grocery store, that we see every single day in our communities, and an impact to them is an impact to all of us.
Well, thank you all so much for joining us for this conversation today. And thank you to the audience for sticking around for this important topic. I hope that you will save the date for our next event, which is Boosting Health Through Economic Policy, Health Systems' Role in Improving Economic Well-Being of Communities. That will be on May 2nd. But until then, I want to thank again our panelists for joining us today. It was a great conversation, and we hope to see you soon.
Thanks for having us.
Thank you.
Take care.
Thank you.